Kala-azar, also known as visceral leishmaniasis, VL, is a severe parasitic disease caused by protozoan parasites of the genus Leishmania, primarily Leishmania donovani and Leishmania infantum. It is transmitted to humans through the bite of infected female sandflies, primarily of the phlebotomys species in the Old World and Lutsamia species in the New World. Kala-azar is considered one of the most serious forms of leishmaniasis due to its systemic impact, high mortality if untreated, and significant public health burden, particularly in tropical and subtropical regions of Asia, Africa, South America, and the Mediterranean. Epidemiology. Kala-azar is endemic in over 70 countries, with the highest incidence reported in India, Bangladesh, Sudan, South Sudan, Ethiopia, and Brazil. The disease primarily affects impoverished populations living in rural or peri-urban areas with poor housing conditions and limited access to health care. Environmental factors, such as deforestation, migration, and poor sanitation, contribute to the spread of the disease by increasing human exposure to sandfly vectors. The World Health Organization, WHO, estimates that there are approximately 50,000 to 90,000 new cases of visceral leishmaniasis annually, with around 20,000 to 30,000 deaths per year, largely due to delayed diagnosis and lack of access to effective treatment. Kala-azar is more common in males than females, and children are particularly vulnerable due to their weaker immune systems. Pathophysiology. The disease begins when an infected sandfly injects promastigote forms of the Leishmania parasite into the human bloodstream. These parasites are quickly engulfed by macrophages, where they transform into mastigotes and multiply within the phagolysosms of these immune cells. The parasites primarily target the reticuloendothelial system, infecting organs such as the spleen, liver, bone marrow, and lymph nodes. As the infection progresses, it causes widespread tissue damage and immune system dysregulation. The proliferation of parasites in the spleen and liver leads to organomegaly and enlargement of these organs. Additionally, the destruction of bone marrow cells can cause pancytopenia, a condition characterized by anemia, leukopenia, and thrombocytopenia, contributing to increased susceptibility to secondary infections and bleeding tendencies. Clinical features. Kala-azar is characterized by a prolonged incubation period, usually ranging from 2 weeks to several months, which can delay recognition and treatment. The early symptoms are nonspecific and include fever, malaise, fatigue, and weight loss. As the disease progresses, more specific features emerge, including fever, often irregular and persistent, with intermittent spikes over weeks or months. Splenomegaly, the spleen becomes markedly enlarged, sometimes extending to the pelvis. Hepatomegaly, enlargement of the liver occurs but is generally less pronounced than splenic enlargement. Pancytopenia, reduction in red blood cells, white blood cells, and platelets, leading to anemia, increased risk of infections, and bleeding tendencies. Hyperpigmentation, darkening of the skin, which is the origin of the term Kala-azar, meaning black fever in Hindi. Without treatment, visceral leishmaniasis can be fatal, often due to secondary infections, severe anemia, or hemorrhages. Diagnosis. Diagnosis of Kala-azar relies on a combination of clinical suspicion, laboratory testing, and parasitological confirmation. Common diagnostic methods include serological tests. Detection of anti-Leishmania antibodies using RK39 dipstick tests is widely used in endemic areas. Parasitological confirmation, identification of mastigotes in tissue aspirates from the spleen, bone marrow, or lymph nodes under a microscope. Molecular tests, PCR-based techniques provide sensitive and specific detection of Leishmania DNA. Early diagnosis is crucial to reduce mortality and prevent complications. Treatment. Treatment of Kala-azar involves the administration of anti-leishmanial drugs, which vary depending on the geographic region, parasite species, and patient factors. Common drugs include amphotericin B, liposomal formulation highly effective with fewer side effects, considered the first-line treatment in many countries. miltefosine, an oral drug effective against VL, often used in combination therapy. Sodium stibogluconate and paromomycin, used in specific regions based on resistance patterns. Supportive care, including management of anemia and secondary infections, is also critical. Post-treatment follow-up is necessary as some patients may develop post-Kala-azar dermal leishmaniasis, PKDL, a condition with skin lesions appearing months or years after recovery. Prevention and control. Kala-azar prevention focuses on controlling the sandfly vector and reducing human exposure. Measures include use of insecticide-treated bed nets and indoor residual spraying. Environmental management to eliminate sandfly breeding sites. Early detection and treatment of human cases to reduce the reservoir of infection. Public health campaigns and community awareness are vital in endemic areas to reduce transmission and improve access to health care. In conclusion, Kala-azar is a life-threatening parasitic disease with profound public health implications. Effective management relies on early diagnosis, appropriate treatment, vector control, and community-based interventions. Despite progress in treatment and prevention, challenges such as drug resistance, poverty, and limited healthcare infrastructure continue to impede global efforts to eliminate the disease.